Hello, employee benefits community. John, just let me know if you all can't hear me. Otherwise, I'm going to assume it's a go. It is my pleasure to welcome all of you to the opening session of EBRI's Policy Forum Week. I'm Tammy Simon, a proud member of the EBRI Executive Committee and longtime EBRI Board of Trustees member. There are three parts of today's session. First, we are going to explore together some groundbreaking, hot off the press new findings from EBRI, as well as the Integrated Benefits Institute on the critical role of utilization, not just availability, in driving the effectiveness of workplace mental health benefits. Drawing from these two large national studies and surveys, the panelists are going to highlight the disconnect between benefit offerings and actual engagement, the demographic and organizational factors influencing access, and the types of programs most strongly linked to well-being, productivity, and psychological safety. And an industry expert is also going to join the discussion to share real-world strategies for closing the utilization gap, enhancing cultural supports, and aligning benefit design and workforce needs. Then at 1:45, we will shift to health savings accounts, HSAs, and hear about the latest EBRI research on HSAs from our outstanding HSA database, and also get a public policy perspective from Mr. HSA himself, which will then dovetail nicely because around 2:10, 2:15, after some voting that's happening on Capitol Hill, we will be joined by Congressman Moore and Panetta, who have both been strong advocates of the employer-sponsored employee benefit system, as well as HSAs. And then we will conclude at 2:30. So a lot of good stuff in the next hour and a half. Next slide, please. Now, please feel free to ask questions throughout the program. It's action-packed, and I'm going to be watching the webinar chat window for your questions throughout. So don't be shy or feel like you need to wait until the very, very end. We'll do our best to answer your questions throughout the session. To ask a question, in case you're not familiar with this technology, click on the chat box at the bottom of the screen, and you may need to move your cursor to the bottom of the screen to let the chat icon appear. Enter your question at the bottom right-hand corner of the screen. You can submit your questions at any point, as I mentioned before. And for those of you that are only listening via phone, please feel free to email your questions to info@ebri.org. That's info, I-N-F-O, at ebri.org. And whether you're on the phone or watching via Zoom, yes, I'll say it 100 times, the slides and the recording will be available on the EBRI website maybe as soon as tomorrow. So you will get a copy of the slides. Next slide, please. All right, so for the first part of our program today, we have three terrific industry experts. And you all have access, by the way, to their full bios in today's materials. First, we will hear from our very own Paul Fronston, who will review EBRI's hot off the press 2025 mental health survey data and findings. Next, we'll hear from Sarah Lee Guyal with the Integrated Benefits Institute, and she will be reviewing the latest IBI survey on mental health. And then finally, Anna Bob, who is the Executive Director of Path Forward, a DC-based health system that has stakeholders from a variety of different organizations and parts of the ecosystem, and focusing on increasing access to mental health care. She's going to be joining us during the Q&A session and to provide some of her remarks and strategies. Now, before we jump in, I want to make sure that we're all sort of starting from the same page. So let's go ahead and get to the next slide and sort of remind ourselves from a data perspective where we are in terms of mental health and why employers should really care about these particular benefits that they're offering to their people. As you can see from this slide, the treatment of people under age 65, which of course accounts for the majority of the working population and their dependents, for mental health disorders has continued to rise since the pandemic. Some of us might have thought that there was going to be a surge around the pandemic and then we would see those numbers drop, but they haven't. And while these may not look like big increases, they certainly still signal the direction of this trend and its immediate impacts on worker productivity, morale, culture, and of course, health benefit costs. Next slide, please. Now, if we look at 2021 and 2023, we compare them, we see that anxiety-related conditions are a primary driver of those increases, although we also see some slightly less significant increases in ADHD, substance abuse, and bipolar and manic disorders. So why is that important? Because the effective treatment of anxiety-based conditions shows generally a high success rate, and if not properly treated, can really severely impact worker productivity and workplace culture. And there's a ton of data pointing to that information. Next slide, please. Finally, the next slide, this slide breaks these data shown by age, which I think is just fascinating, showing that younger workers seem to be impacted as much or more by these conditions than older populations, with the exception of substance abuse, which appears to get worse as we age. So taken together, this paints a troubling picture for the country's workforce. So now I'll hand the mic over to Paul. And Paul, can you please enlighten us on what your 2025 data can show us and whether it's consistent with what we've seen through 2023?
Thanks, Tammy. Appreciate you moderating this discussion. And as Tammy said, we have some hot off the press research from our 2025 Employee Mental Health Survey. This is work that I did with Bridget Bearden, and I do want to thank Anna and the Path Forward for making this work possible. Next slide, John. I just have a few minutes to go over this. Just a real quick note about methodology. We conducted the survey in March and April. It was a 15-minute survey that was conducted online. Over 3,100 workers were interviewed between the ages of 20 and 74. They had to have coverage through an employment-based health plan, whether it was their own, a spouse's employer, or a parent's employer. We didn't include the self-employed, and there's other information down here that's relevant to the methodology that you could look at your leisure when you get the slides. On the next slide, you'll see what I think is a very important finding, which is that we asked the workers not only if they had a mental health condition, but if someone in their family had a condition, and very specifically, not just the family, but really that, I hate to use this term, but that health insurance unit, people covered by the workers' health plan. So there may be cases where someone in a family isn't covered by the workers' plan and they have a mental health condition that we're not picking up, but I think in large part this would be representative. And we find that among anyone on the health plan, 27%, so just over a quarter of respondents said that either they or someone covered by their plan had a mental health condition. And you can see how that breaks down between respondents at 19%, children under 18 at 9%, a few adult children between 18 and 26. Not surprised it was so low, because you're going to have fewer people with adult children on the plan, and then the respondent's spouse or partner at 7%. Next slide, please. And when you look at the mental health conditions that people have, this is only based upon a sample of 3,100 people in the subset that report they have a mental health condition, but it looks identical to work we've done with claims data on millions and millions of people when it comes to the percentages and how they rank with anxiety, major depressive disorder, and ADHD being the top three, as we've seen in the past. Next slide, please. We did ask in the last 6 months, were you ever not able to get medical care or tests or some type of treatment you or your doctor thought was necessary? And we find that among people who have someone on their health plan with a mental health condition, they're twice as likely to report yes, that there was some issue getting needed care. 31% among those with a mental health condition versus 15% among those without. I think the 15% is also significant, but this difference is eye-opening. Next slide. When it comes to the type of care that people were not able to get, the big differences here, and you can't see me pointing at the slide, but the big difference is that second set of bars related to mental health or behavioral health care. And then the fourth set of bars, the prescriptions for mental health or behavioral health. That's where people with mental health conditions were mainly affected compared to those that where there was no one with a mental health condition on the health plan. Next slide. When it comes to the reasons, the main reasons why people were not able to get the care that they thought they needed, again, the big differences happen to be with respect to the doctor refusing to accept insurance, so network issues, and not being able to take time off of work or get child care. So just the ability, which isn't necessarily a health plan issue, but certainly an issue when it comes to accessing health care. And then real quickly on the next two slides, the first one, we did ask these questions about engagement in health, whether people checked their health plan as to whether it would cover their mental health care or medications, whether they checked the price of doctor visits or medications or other mental health care services. All these questions here are related to receiving mental health care. And we do find, and not surprisingly, those with someone on a health plan that has a mental health condition are more engaged in these aspects of healthcare than those that don't have a mental health condition. Not a surprise, though we do think there are some people that do have a mental health condition that don't report it. There's underreporting. We have evidence of that in the survey, like other surveys. But even when you look on the next slide and see the engagement with respect to physical healthcare, you see the same pattern. People with mental health conditions are more likely to be engaged in various aspects of their healthcare than people that don't report having a mental health condition. So those are just some highlights from the findings. It was a pretty long survey, lots of other interesting findings. Tammy, I look forward to the Q&A, and I'm going to turn it back over to you.
Great. We did get a couple questions here, Paul, for you. And while the data is sort of fresh in everybody's mind, I thought I'd just jump in and ask right now. So first of all, something that you said earlier was real interesting to me. Your survey basically oversampled workers and households affected by mental health and substance abuse conditions. Again, in a very practical way, because I hope that everyone today can walk away with some very, very tangible action items and takeaways from the data that everyone is providing. What stood out to you most about the prevalence of those conditions within families, and what do you think employers should interpret from those findings?
Yeah, we did the oversample because we knew if we wouldn't have enough sample of people with mental health conditions,
Right.
Even though it turned out to be 1/4, right? There's concern about that. So we did oversample. And I think it was a striking finding of just how common these conditions are when you look at the family level, or the health insurance, coverage level, as opposed to just the individual worker. Many households have more than one person affected, which means that the stressors extend beyond the worker to their dependents.
Mm-hmm.
For employers, I think this reinforces that supporting mental health isn't only about offering counseling to workers and the coverage. It's about recognizing that there are spillover effects in terms of in terms of productivity, absenteeism, and overall well-being, things we've been talking about a long time, when not just a worker might be struggling with a mental health condition, but a family member as well.
Now, did those findings also we got several comments about the age slide that I showed earlier. Are you seeing sort of consistency in terms of age, whether it happens to be the employee or it's their family member dependent?
Yeah, I'd have to look more carefully at the composition within the family, but certainly the age patterns reflect what we've seen in the past.
Yeah,
At the
which
top
is
line.
pretty troubling, right?
Mhm.
And one more quick question before we move on to Sarah Lee. The data highlighted the reasons why workers and their families couldn't get the care that they needed, which we have been talking about access to mental health care certainly since the pandemic, but it's been an ongoing issue. Any specific barriers that stood out to you in particular, especially given that we've got two congressmen coming online in just a little bit, something that maybe we might want to think about from a policy perspective?
Yeah, certainly network adequacy seems to be a barrier. Employers are trying to address it. Cost is always a barrier for a number of people. We know that employers can expand virtual care networks or contract with vendors to close those gaps. But there are broader workforce shortages in mental health care that go beyond what employers can fix. And those might require, and I'm not advocating for this, but they might require policy solutions
Mhm.
to expand training and supply of providers.
Right, right. And that's a great example of where we need to include the entire healthcare ecosystem in the conversation as opposed to just those of us in the benefits community. Great. Well, thank you, Paul. And I'm sure we'll have additional questions for you in just a bit. So don't go far. All right. Sarah Lee, can you now give us some insights on what you all at IBI have been taking a look at, please?
Absolutely. The Integrated Benefits Institute, I am the senior researcher there, and we just conducted our mental health study for this year. And we looked at the impact of mental health benefits on well-being and disability. We analyzed a survey of 1,200 employees, just over 1,200 employees across different industries. Um, and across the United States, and we found challenges, the conventional wisdom of how organizations should approach mental health. About 40% of employees never use the benefits offered by their companies, despite widespread availability. But more importantly, we discovered that it's not just about having those benefits, it's about employees actually using them. So the engagement. Our data showed that active utilization of the mental health benefits demonstrates 287% stronger correlations with employee well-being compared to simply just having it there for them and not encouraging use. But here's what that kind of intensive engagement looked like in practice from our data. Employees using six or more mental health benefits, showed 17% higher well-being scores. And we did workplace psychological safety and a presenteeism scale and a psychological well-being score scale in our survey. And they also reported 30% better psychological safety ratings and critically, for business outcomes, 19% lower presenteeism when they use six or more mental health benefits. But here's where it gets interesting. Company size amplifies everything. So in organizations of 1,000 or more employees in our sample, the link between benefit utilization and productivity was 3 times stronger than those in the smaller companies. So, those larger companies may have the infrastructure to really push that engagement narrative and could be where the smaller companies learn from or get help from. But we're leaving potential on the table because 1 in 5 employees in our survey reported little to no awareness of what's available to them. If you can go to the next slide, we found that not all benefits are created equal. So our analysis revealed a clear hierarchy. The highest impact was manager training, flexible work arrangements, peer support, and cultural interventions. And that's had the highest impact on psychological safety. And we also looked at moderate impact, like digital tools and meditation programs. And traditional kind of clinical services like insurance covered therapy or EAPs had kind of a surprisingly low impact. And it kind of shows us that, we've been heavily investing in clinical solutions while underestimating the power of organizational culture and managerial support. Um, and that utilization pattern we saw really varied by demographic. So women used more benefits than men, parents engaged more than non-parents, and younger employees had worse well-being scores and tended to use more services or benefits. So your strategy needs to be as diverse as your workforce. Um, we had a few strategic kind of recommendations. If you can go to the next slide. So measure utilization and prioritize it, track who's using what and why others aren't. And that's really where kind of your real ROI indicator comes in. Address your don't know population. 20% of your workforce may not even know what's available, and that's just communication. it's not just communication, it's an equity problem. And reallocate some of your budget. So consider shifting some of your spend toward cultural interventions, manager support, peer manager training, peer support, that flexible policy in the workplace, rather than expanding kind of those underused clinical services. The evidence here was pretty clear that mental health benefits only work when employees actually use them, and that's not surprising. So the question isn't whether you're offering enough programs, it's whether you're actually driving meaningful engagement with what you already have. Measure utilization rates tomorrow, identify your don't know population. And in the battle of employee well-being and productivity, it seems like culture is beating clinics. So the gap between offering and engaging is where your biggest opportunities live, and it's time to mind that gap.
Wow, fascinating, fascinating research. Thank you so much, Sarah
Thank
Lee.
you.
One question that is just sort of, coming out that I think, I doubt I'm the only one thinking about it, is, the research shows obviously significant demographic differences in mental health benefits usage. That was the primary focus of
Hmm.
what you did. And it sounded like it was women, parents, and younger workers that have got, the most utilization. So,
Yes.
and given what you said about culture, given what you
Mhm.
said about offering a wide variety of different offerings, do you have any suggestions for what employers should be thinking about how they balance targeted outreach to those underutilized groups like older employees or men, for example, while also continuing to support those that are already engaged?
Yeah, absolutely. I think the key is to use different messages, not different benefits. So your benefits don't have to necessarily change, although it would be good to have certain one tailored depending on your population. But for underutilized groups like men or older employees, have male leaders and senior male employees talk about using those benefits.
Mm-hmm.
Um, Focus on productivity and performance, the metrics that is related to using those benefits. And for higher utilizing groups, women, parents, younger workers, keep the programs they already love, like flexible work, peer support, um, and invest in those programs that you already have, that you're already seeing usage in, and then have them try to encourage colleagues within their demographic to use the benefits, kind of a peer support, word of mouth. Word of mouth is such an underrated application or method. And I think that manager training really would help for the high utilizing groups to see that, their managers are supporting them and then they can relay that to their colleagues.
Great
So,
suggestions. Yeah,
yeah,
I'm sorry, go ahead.
no, I think just everyone gets access to everything, but you advertise it differently to different people.
Right.
So I think that's same benefit, different pitch.
Well, hey, we all know that that's happening to each one of us on social media. So,
Right.
why should this be any different? And I know that there are a lot of employers that are out there really focusing on creating personas and personalized
Exactly.
messaging so that we get to the right population. So, I think what I'm taking away from you is that that's working and that we should do more of that, but make sure that everybody has access to all of the different resources because everyone is different. Other than sort of the typical, group health plan covered mental health services, the pharmaceutical services, the employee assistance program, counseling stuff, you mentioned time off. Any other maybe less common types of services that you're starting to maybe see that employers are offering and that have seemed to work or are gaining popularity?
Yeah, surprisingly, in our survey, we found that the meditation apps were very highly correlated
Mm,
with better
mhm.
well-being. Um, we don't know why, but that was quite interesting. It could be linked to younger employees in our survey using more services. It could be accessibility. It could be just, that that's what they have time for. But
Mhm.
we saw that, yeah, definitely the meditation apps was something that stood out to us. Um, and you said it, and I'm going to say it again, that flexible work arrangement. I
Yeah,
think people don't often think of that as a mental health benefit, and it is. It's not just the way you work. Flexible work arrangements gives people the freedom to fit whatever they have to fit into their day, especially parents or those in the sandwich generation that are caring for children and elderly parents. That
hmm,
flexibility really helps them to um, feel valued. And I think it really controls their presenteeism, because when they're actually when they're showing up to work, they're focused on what they're doing and not thinking about when can they have a day off or a half a day to get to this appointment, or I have these things to schedule, and it messes with their anxiety. And so I think it kind of all goes hand in hand.
right.
Um, yeah.
Great. Well, thank you so much. That's great. I already see a couple other questions coming in that I'm going to give to both you and to Paul in a second. But I really want to shift gears a little bit and move to Anna,
Mhm.
who is uh, our resident expert here on some of the practicalities of these items. So, Anna, why don't you share some of your prepared remarks, and then we'll get to some of the questions that I know have been coming in for you.
Oh, okay. Well, sure. I'm not sure. I think that I just am here to kind of, well, first of all, thank everyone for all of this research that's really moving the field forward. You know, we were involved, Path Forward was involved with Paul with the first study, and really looking at the healthcare benefit and and doing a deep dive on mental health care in the benefit.
Mhm.
And I think what our findings really show with that first study that Paul did is just that having insurance is not a guarantee for mental health care access.
Right.
And so, I mean, we just, I think employees know this, and I think the survey brings it home that even when you have this great insurance from an employer, we're still having trouble getting mental health care. So they're struggling, but it's not for lack of trying, as Paul's, data show.
Right.
So, we are still focused with Path Forward on this really, the confidential, private, medical, clinical intervention for mental health care. But what we think with the results and what we think the key finding is really getting that care a lot earlier. So we really need to get access. We need to treat mental illness, in our opinion, like another chronic condition, like heart disease, by intervening earlier. And so for us, seeing that the data was showing so many folks with who were reporting a mental health condition, either them or a family member, using emergency rooms and then using them at such high rates, that was
Hmm.
kind of a alarming finding. And obviously, emergency rooms shouldn't be frontline treatment for mental illness. We want to focus on, just like with heart disease or diabetes, really taking an early intervention approach to mental illness. If something's wrong, we want the employee to get help and get better. So that was sort of the top line finding, I would say, of the survey.
That's great. Good. So any specific suggestions other than what you just described in terms of the early intervention, which is a suggestion for both physical and mental health. So it's not particularly surprising. And we all know that emergency room costs are much higher than what regular in-office visits would be. But any other suggestions for employers to really advance better mental health for their populations, things they should possibly be tracking or taking a look at when they're looking at their own specific data?
Yes. So we really feel like the low hanging fruit here is networks, network adequacy, integrated care, specifically collaborative care, and then telehealth.
Mhm.
Um, and I would add to that probably screening, which is part of integrated care. We all know these things work. The problem is we also know that they're not scaling fast enough in practice. And an example is collaborative care model, which is sort of the state of the art in integrated care. And our coalition just released data from Milliman. It was a claim study of more than 200 million Americans, and it showed that it has grown 10 times, over the last 5 years, but is still only reaching a fraction of those who could benefit. So, from the perspective of employers, things like this, telehealth, network adequacy, and even integrated care are all things that are really highly visible through claims data, which is why I think it's low-hanging fruit. So I think, get the claims data, get visibility into what's happening. One of the members of our coalition, our partner, the National Alliance for Healthcare Purchasers, they just completed a study showing that employees who have complete and transparent claims access are twice as likely to engage in federal and state health policy. They're much more engaged, and they're also more likely to really be implementing positive strategies. That said, of course, getting that visibility isn't always easy for them. I would think all the employers at this table are finding that really, they can get that claims data, but monitoring claims data is one. The other one is really, as Sarah Lee said, is just monitoring the utilization of your employees. It's really flipping the script to thinking that, mental illness has a stigma and we don't want to talk about it, to thinking not only do we want to talk about it, but we want to intervene early. We want to get help quickly. And so for that, I think some of the strategies that Paul and Sarah Lee were talking about, communication, about demystifying and destigmatizing mental health services, not just mental illness, but that, let's get folks in if we see any signs of trouble, working with hiring managers to, again, help them maybe in a gentle and kind way, in a non-judgmental way, be able to talk to an employee about if there's a little bit of trouble. Can you encourage someone to use the resources that the company provides?
Yeah, I think that's great. And one of the things that that I've certainly seen is the training of the managers piece that you and Sarah Lee have both talked about. I think it's key. There are a lot of organizations that are now including training that specifically directs managers to help identify issues. If you see some signs, educating them that, mental health challenges should not be judged harshly. They shouldn't be stigmatized. You shouldn't penalize people for them. And then making sure that those managers are proficiently understand all the different resources that are being offered by the organization. So having the managers, as we said before, people talking about it in the workplace, but having your manager know what benefits are available, resources, instead of saying, oh, well, go ask HR, right? Having them actually understand what's being offered. And also maybe sharing some of their own vulnerability and their own personal stories of having tapped into some of that if it's relevant. So if Paul and Sarah Lee could get back on, we have a couple more questions here, and then we will be moving to the next part of the program. So one question that we got in the chat is, can you point to studies that show the effect of enhanced access to these types of benefits to overall health of employees and their dependents, as well as savings as a result? So said another way, what's the ROI in all of this? So I will, let anyone jump in that wants to say something first.
Sarah Lee, is that something you've looked at IBI?
Not particularly ROI specific, no. We've kind of just looked at, in this particular study, just the difference in the well-being scores, but not in claims or productivity or mental health or healthcare costs. And I don't know off the top of my head studies, and I'd be happy to look into it, but I don't know any off the top of my head.
We haven't done those kind of studies in the mental health space. We have done them with respect to other benefits or other healthcare conditions, where we have found that changing plan design in a way that removes what appears to be a cost barrier, even though sometimes it isn't, or it doesn't turn out to be, does result in improvements in medication adherence for people with certain chronic conditions. So the evidence is out there, and that's something, I'm always looking to do studies on medical cost offsets and, ways to innovate around plan design to engage people in their health and to improve their health. And, this is certainly an area that's right for that.
And I would say, I
Absolutely.
would add that Milliman has done some really good studies on total cost of care and mental illness and also early intervention, and that there are also some very good studies on some of the best practices showing that there's a reduction, specifically intervening early in primary care on total healthcare costs.
Well, and it's interesting because we got another question while you guys were talking that's very, very similar, but actually expands the framework a little bit. Because look, we all know that physical, mental, as well as financial health are very much aligned, and we'll be talking about that later this week. And then, EBRI will have some other programs later in the year on retirement. But one of the specific questions that was asked by a former colleague of mine, hello, is putting, resources, time, and money towards culture and communications, certainly to raise awareness of mental health benefits, often runs into some resistance when it comes to implementation. It can be tricky. I've certainly seen this because there are a lot of people that say, well, I can't talk about that, right? That's, HIPAA. And we overextend HIPAA, I think, to basically cover us from talking about things that maybe we don't feel comfortable discussing. So we're being asked, what recommendations might you have, or have you seen, or can we say more about what's that ROI for investing in those types of approaches that you share with those managers, the leaders, or maybe some cultures that are perhaps a little bit resistant to really trying that destigmatizing concept that all three of you were talking about?
I think I haven't done ROI specific on mental health like Paul just said, but if you look in your own book of business, whatever the employer is, and you look at your spend for mental health claims are up 15% in the last couple of years, and they're growing. It stands to reason that putting more money into more benefits without promoting them or promoting engagement is basically, money down the drain. So if you're investing in the solution, you need to invest in your people using the solution. Um, it's just clear and simple in our study that using the benefits that you have, not just having a menu of them, um, drives that well-being scores up. And you can assume from that, if well-being scores are up, healthcare costs related to mental health should be down in your population.
The
Really
ROI
good point.
question I always find interesting
Mm,
because I don't think we've ever asked an employer, show me your ROI on your traditional
mhm,
medical
mhm,
benefits,
mhm,
right? Yet every large employer offers health benefits to attract the kind of workers and keep the kind of workers that they want. They do so because they know it affects worker health, family health, and productivity. Um, Yet, an employer that spends $2 billion on the health benefits for their workers wouldn't put that to the test, wouldn't put, that to an ROI test. But when they were adding wellness programs, health
mhm,
risk assessments and biometric screenings for a fraction of the $2 billion, they put that little sliver of cost to an ROI.
mhm,
So when I see ROI, I always think about, if employers believe that this is going to work and that it's good for their workers, access to mental health benefits and changing the culture and reducing the stigma. And I would say, even thinking differently about what parity means,
mhm,
right? There's a lot of parity on paper, but in practice, there's still some hurdles, right? When
mm,
it comes to uh, the stigma and making sure people have access, and employers many employers, we shouldn't generalize every employer. There's a million large employers out there. But many employers, especially since COVID, have doubled down on access to mental health care services. And they know it's the right thing to do. They know that there's an impact on their workers and their families if they don't. I don't know that you need an ROI uh, to,
mhm,
to justify it.
Well, so, one thing that I'll mention, Paul, is, in my many years, far too many to say out loud, consulting, we're asked the ROI question all the time because we're helping design the programs for our employer clients and trying to decide how different resources are going to be used. And, being able to track the return on that investment is actually not that hard if you know what to look for. We know that there are certain physical ailments that are highly susceptible to stress-based mental health issues, right? As a matter of fact, getting back to expanding the way we're thinking about this a little bit, in the United States, the number one mental health stressor, and this is different, by the way, than any other country in the world, the number one mental health stressor that leads to physical health related conditions is actually either actual or perceived financial insecurity. So if people are worried about where they're going to get their next paycheck, or they're worried they're going to get fired, like so many people are right now, for example, in the United States, right? That stress is creating some mental health conditions that are going to rear themselves into some physical ailments. And so looking for those threads and kind of looking beyond what the most basic data is showing, but trying to find those connectors that's evidence-based, I think is something that clearly several of the folks that are listening are asking for and looking for. So I think it'd be interesting. Maybe we can all chat afterwards and think about how we can double click on some of that data to see if we can start finding a few more of those threads. So one more question that came in, and then I think we'll close this particular panel up. But I wanted to kind of finish that frame of reference with respect to retirement benefits, because I love this question. Do you have information on the relationship of mental health and flexible retirement arrangements that allow for phased retirement or support people during that transition? And no, that question wasn't covered, or the topic wasn't covered. So thank you very much for your question. So now it's linking retirement with mental health. Any thoughts?
Yeah, we didn't ask that specifically in our mental health survey. It would probably only apply to a segment of people that are old enough to be thinking about retirement.
Right.
And of course we do I'd have to check the other surveys here we do at EBRI, because a lot of them are cross-platform in terms of dealing with both health and retirement issues, and see if we have anything that could address that.
Yeah, same.
Yeah, I don't have anything specific. I just would say, though, that what we do know about mental health benefits and treatments is that they work. Brief interventions work, and they work really well. We are struggling, of course, always to get access to those treatments, but anxiety is just highly treatable with even short bursts of fairly low cost therapy. So I think for me, the bottom line is just for whatever challenges people are facing, let's not be afraid to encourage them to talk to someone to get a little bit of guidance and help with that challenge.
One more lightning round real quick. Remote hybrid work and mental health. Thoughts? Paul?
Positive impact on my mental health. Absolutely. I would think, a lot of workers, it gives them a little bit of free time to exercise, get more work done. You got to find the right balance. You got to find the right employees that can work remotely and be productive. So you don't have, some people have to be in an office. Some people want to be in an office. And it all goes back to having the right people on the right bus. And sometimes that bus is going to be in person. Sometimes it's going to be remote. And sometimes it's going to go back and forth depending upon the needs of the business.
Sarah Lee?
Yeah, completely agree. My research shows it time and time again. Flexible work, remote, hybrid, or your ability to choose is just correlated with better mental health across the board.
And your study broke those out in terms of, paid time off, for example, versus hybrid versus remote, because there are still employers that are continuing to sort of think about those policies and whether they should refine them.
Yeah, so we actually just looked at flexible work policies, and we defined that as, hybrid or remote, or like the choice if you can choose. And yeah, for younger people, it didn't really have that much of a correlation. Definitely for parents,
Hmm.
for women, it did. Um, one of our assumptions is that younger people are interested in that socializing aspect of being in the office,
Mhm.
whereas, as mid-career parent, you did that, you're ready to focus on other things, you don't want the commute. So yeah, definitely it is positively impactful for mental health well-being.
Anna, last comment?
I don't have anything on that. Just thank you again. Great webinar. Thank you.
Well, good. Thank you so much to all three of you. And don't go far because I'm sure we'll have some more questions that arise. But I think let's go ahead and bring on the second panel. Let me do some
Thank you.
introductions while other folks are coming in. So now we're moving the conversation over to health savings accounts, HSAs. And with us today, we have two terrific experts in this area. We've got EBRI's very own Jake Spiegel, who is going to present EBRI's latest HSA research from really, I think it's one of the largest HSA databases in the country. So incredible amount of data from that data lake. And we also have Mr. HSA himself, Roy Rantham, who led the Treasury Department's implementation of HSAs after they were enacted into law back in 2003, and then served as President George W. Bush's healthcare advisor at the White House. And I had asked both of them what their favorite movies were to see if that could give us any insights on their psyche. So fun fact, Roy's favorite movie is Monty Python and the Holy Grail, a personal favorite of mine. And Jake's is Lord of the Rings, Return of the King. But he specified, and this is the researcher in you, Jake. It has to be the extended edition, which I just thought was really fascinating. So, so with that introduction, Mr. Baggins, what does your research show us in the world of HSAs?
Yes, the extended edition is key. I need all 4 hours and 20 minutes of that. So thanks for that great introduction, Tammy. I'm happy to share some insights on HSAs. Our database can play a really pivotal role in informing public policy because good public policy can't be crafted if we don't have the details straight to begin with. So just on this first slide, I'm going to give a very brief overview on EBRI's HSA database. We established it about 10 years ago, and it has grown to contain data on over 14.5 million HSAs containing $48.5 billion in total assets. Depending on who's doing the accounting here, that's somewhere in the neighborhood of 40% of the entire HSA universe, both in terms of accounts and also assets. And just to hop on the soapbox for a quick moment here, there just isn't great data on HSAs out there. Large surveys like the Survey of Consumer Finances don't disaggregate HSAs from other types of accounts. Other surveys like the Medical Expenditure Panel Survey might be able to tell us how many people have HSAs, but they don't have any data on things like contributions, distributions, or balances. And so our HSA database, I think, plays a pretty pivotal role in informing the public on how HSAs are actually being used, and that can be used to craft better policy. We get data from a wide variety of record keepers, so we feel like it's pretty representative of the entire market as a whole, and it allows us to draw some pretty robust inferences as a result of that. And then every year we produce 2 updates to pieces of research that we do every single year. One is a cross-sectional that looks at how HSAs are being used year after year after year, and the other is longitudinal, how that compares to trends in previous years. On the next slide, I'm going to briefly touch on something we started doing this year. We started looking at results both in terms of nominal dollars and also real inflation-adjusted dollars. We never adjusted for inflation in the past. It really wasn't that big of a deal when inflation was running at 1% every year from 2010 to 2019. But ever since we've experienced a period of above trend inflation, I thought it was pretty important to adjust going forward, and then taking a look back at and seeing how in real terms, how contributions, distributions, and total balances compare today to a couple of years in the past. And what we find is that on a nominal basis, balances have nearly doubled in the past 10 years. We've seen 2013 an average balance of 2507, increasing to 4747 for 2023. But then once we start adjusting for inflation, we see that those increases are a little bit smaller. And in fact, over the past couple of years, on an inflation adjusted basis, the average HSA balance has actually remained pretty stable, range bound by about $20 going back to 2021. And some of this is just due to the fact of a lot of the HSAs in our database are relatively new. 13% were brand new last year, and over half of the HSAs in our database are less than 4 years old. So some of that average balance remaining somewhat stable is just driven by the fact that there seems to be a lot of churn and a lot of new HSAs out there. Next slide. We also take a quick look at average nominal and inflation adjusted contributions. And in nominal terms, we see that contributions are basically at their all-time high. But once you account for inflation, they were actually a little bit higher in the late 2010s than they were today. And this is important because the statutory maximum for HSA contributions is tied to inflation. And as a result, the statutory maximum contribution increased pretty dramatically between 2021 and 2023. We see in all sorts of areas of social sciences that people's behaviors are sticky. So undoubtedly, some of this is driven by people not really staying up to date on their contributions. I am a guilty party. I have not changed it since last year, and I should do that. In fact, I'm going to make a note and make sure that I reach out to our HR folks and make that adjustment so I can get my statutory maximum contribution. But overall, not that many folks are contributing the statutory maximum. We find that only about 11% of HSA account holders contributed the most that they were allowed to. And that's a little bit more than contribute the statutory maximum for other types of tax advantage accounts like FSAs in particular. Very few people contribute the statutory maximum to FSAs, but it is also a lot less than people who contribute the statutory maximum for other types of tax advantage vehicles like IRAs. On the next slide, we hear all the time about how one of the best ways to take advantage of the tax benefits that HSAs have to offer is by investing assets. And we've seen the propensity for folks to invest their HSA assets climb slowly but steadily over time. About 15% of account holders had assets in their HSAs invested in assets other than cash. And there are a few factors that correlate with the propensity to invest, namely account tenure and total balance. And even account tenure and total balance are pretty strongly correlated with each other. And that's because some HSA providers require that account holders have to hit a certain threshold before they're even allowed to invest. For some providers, it might be $1,000. So by introducing that little bit of friction, you're going to weed out some folks who are not necessarily on top of their HSAs, and then also weed out some folks that might be using their HSAs more as a spending vehicle. And they might not hit that $1,000 threshold for very long if they are using their HSA as sort of a pass-through spending vehicle to get tax advantages for their expenditures on healthcare spending. But the propensity to invest is strongly correlated with account tenure, because the longer you've had your HSA, the longer you've been able to accumulate a balance, and then also strongly correlated with total balance. People might be looking to target a certain threshold, whether that's they might save what they need to cover their deductible or their total out-of-pocket maximum before they're comfortable saying, okay, I'd like to subject some of this money to market risk. And there's also one other factor that the propensity to invest is correlated with, which I'll cover on the next slide, which is employer contributions. We see one of the stronger findings in each year that we do this, we do our HSA studies. One of the more consistent and strong findings that we see is that the presence of an employer contribution is correlated with a couple of beneficial attributes. First, the presence of an employer contribution to an employee's HSA is correlated with higher average contributions. We see on this chart here that the presence of an employer contribution actually decreases the employee contribution slightly. It was only $28 last year, but in the past we've seen slightly larger deltas. But once you take into account the employer contribution, the combined total contribution tends to be significantly larger. We also see that the presence of an employer contribution increases the likelihood that an account holder invests. We see that folks who have an employer contribution to their HSAs, 18% of them invest compared to 12% who do not have an employer contribution to their HSAs. So with that sort of level setting, providing a little bit of basic and high level context to the HSA market, I'm going to turn it over to Roy now, who will do a little bit of a deep dive on policy trends in HSAs.
Thanks, Jake. HSAs have been a passion of mine for the last 20 years, and I'm excited to be able to present to everyone today. Let's just dive right into the next slide. What I want to talk about are the HSA provisions that were included in the recent enacted HR 1, the One Big Beautiful Bill Act, and try to clarify some things that I continue to read in the press suggesting that there were other provisions that were enacted when in fact they were not. So I want to make sure that everybody understands there were only 3 provisions that were included in the final bill. A telehealth safe harbor, some provisions related to direct primary care, as well as bronze and catastrophic plans. So let's go to the next slide and talk about the telehealth safe harbor to start off with. To me, this should be most familiar with many people. During COVID, Congress in the CARES Act created an opportunity for all health plans to cover telehealth services without any deductible and without any cost sharing if the health plan decided to do so. And this was extremely important for the so-called high deductible health plans that make people eligible to contribute to an HSA. Obviously, if you understand all of the HSA rules, unless the telehealth benefits were for preventive care, the deductible would otherwise have to apply. So this has been a provision that many people have become accustomed to. Unfortunately, it had expired at the end of last year and once before that, but was extended. And so now, 7 months into 2025, everyone was wondering if there was actually going to be an extension of that telehealth safe harbor from the end of last year. And I'm pleased to announce that yes, there was. It is retroactive to the beginning of this year, and it is finally permanent. So we do not have to come back and debate whether or not to extend this yet for another year or another 2 years. So the good news is that going forward, and again, including back to the beginning of this year, you can receive telehealth services without applying a deductible to those services and for little to no cost sharing if your health plan chooses to do so. It does not have to be limited to just preventive care services either. This is all services that are provided through telehealth, and I'm delighted that this will not be expiring anytime soon and will be permanent unless Congress decides to rescind it at some future point, but we're not going to talk about that. On the next slide then, another provision dealt with one of those things that usually canceled people's eligibility, having met maybe all of the other requirements, but the relationship that they had with their primary care doctor was one where they were paying that doctor a monthly fee rather than on a fee for service basis. And so any of those individuals who were previously enrolled in one of these kinds of arrangements, that was considered to be other disqualifying healthcare coverage that prevented you from contributing to your health savings account, even if you were enrolled in the right kind of high deductible health plan. So that barrier has now been removed. On the next slide, we'll see that there are specific requirements that these DPC arrangements must meet, and all of these new requirements are going to begin applying as of January 1st of next year. Number one, there is a limit on the types of services that those physicians can provide under these arrangements. And I don't think this is a huge surprise, but if you look at what primary care physicians do, generally they do not provide services that require anesthesia. They generally do not provide prescription drugs, although they may prescribe them. And they typically do not do many laboratory or diagnostic services in their offices, and that requirement will remain. There is also a new limit that will apply to those monthly fees for participation in one of these arrangements. I think today we will find fees maybe all over the map, and those who might consider DPC arrangements to be concierge care, I would argue that these are not the same as concierge care, although the definition is somewhat in the eye of the beholder. But the fees for these arrangements will not be allowed to exceed $150 a month for a single person, or $300 a month if there are two or more persons being covered under that arrangement, essentially a family of a couple people. So if there is an arrangement that you participate in that charges more than these amounts, these are not going to be considered DPC arrangements, and that exemption from the HSA eligibility requirements will not exist. However, if your fees and all these other requirements are met, you will be able to start using your HSA funds tax-free to pay those monthly fees, reimburse yourself for any monthly fees that you're paying for your arrangement with your primary care physician. So these are two big changes related to how direct primary care arrangements interact with HSAs. So no longer are they disqualifying for your ability to contribute to an HSA, and you will be able to use your funds going forward as of January 1st to pay those monthly fees. And then our final provision that was included in the bill was an inclusion of bronze and catastrophic plans in the individual market as newly HSA qualified plans. Now, I want to make sure that people understand, what role bronze and catastrophic plans are playing in the market today. In general, a bronze plan is designed to cover only 60% of the total benefit costs, and these plans generally have the highest deductibles as well as the highest out-of-pocket limits than plans that you might otherwise see, such as silver, gold, or platinum plans, also in the Affordable Care Act state insurance marketplaces. The catastrophic plans have equally high deductibles as well as out-of-pocket limits, but they generally do not cover anything except 3 primary care visits before that deductible must be applied, and generally are limited to individuals who are under 30 years of age. So those are the types of policies that are out there today, and will then, as of January 1st, become newly eligible for health savings accounts. So if we go to the next slide, as of January 1, all of those plans, as long as they are ACA qualified, are going to be HSA qualified as well going forward. And this is going to be very important in the marketplace for future growth of HSAs, because as of 2025, there are already over 7 million people who are enrolled in these plans. Now, we want to make sure that they all understand that they're going to be HSA eligible, again, assuming they meet all of the other HSA requirements as of January 1st of next year. So we want to focus on making sure that those individuals understand this new value proposition for them, and it may present an opportunity for more people to sign up for those plans switching from perhaps a higher metal tier plan such as silver or gold, or perhaps looking at the HSA plans for the first time, using funds through their employer's individual coverage HRA as they're making their own choice of health plan in the marketplace. Next slide. So those are the three provisions that are in the new law. And I want to be clear that these following couple slides are the provisions that were not in the final law. They were in the original House bill, but they did not make it into the final law. So if you see something in an article that is online or somewhere else that says that some of these other individuals who I'm going to describe here are going to be HSA eligible come January 1st, that is incorrect. And I've been trying to reach out to the authors of those articles and ask them to correct those articles because they're definitely not true. So in the category of those who might newly become eligible to contribute to HSAs, but didn't because they weren't enacted, includes seniors that are enrolled only in Medicare Part A, workers that have access to employer-based health clinics that somehow conflict with the HSA requirements, and those individuals that have a spouse that participates in a healthcare FSA through their own job, and by virtue of that coverage ends up being disqualified for the HSA, even though they thought they've done everything else to maintain their HSA eligibility. On the next slide, there's another group of individuals that could have benefited if these provisions were enacted, but they were not included. And that includes those individuals with incomes below $75,000 for a single individual or $150,000 for a family, who would have been able to double their HSA contributions under this provision in order to help them put aside additional money to meet those higher deductibles under these plans. We also missed out on those individuals who are married and are both 55 and older, looking forward to avoid a so-called marriage penalty, where they are required to have separate HSA accounts, if for no other reason than to make their $1,000 catch-up contribution for the year. Many people have said, just for the $1,000, couldn't we possibly put that into our spouse's account so that we don't have to open up another HSA, have to worry about managing two accounts, possibly having to pay fees for a second account, etc. But the law does need to be changed, and unfortunately, it was not. And then the last provision in this grouping includes those individuals who may have had unspent funds in their healthcare FSA or their healthcare reimbursement account and are looking to transition to an HSA program under their employer, which would allow them to carry over some of those unspent funds and transfer them to their HSA, which would help them in funding their new HSA as they get going.
And Roy, this is perfect timing because I believe Congressman Moore will be joining us in just a bit. And boy, oh boy, we can ask him why they didn't make the cut, and if he thinks that that maybe we will be able to look forward to them making it in future bills. So please do not go very far because you're here to keep all of us honest on the public policy front. Let's see here. While we are waiting for Congressman Moore to join us, let me just give you all a little bit of background. Congressman Moore is from the great state of Utah. Among many other impressive accomplishments, he serves as the first ever Utah Republican on the House Ways and Means Committee, where he sits on the Health, Social Security, and Trade subcommittees. And he was also recently named the House Budget Committee Health Task Force co-chair. And he was also a key leader in the HOPE Act. So we will welcome him in just a couple minutes. We're also going to be joined by Congressman Panetta, who is a Democrat and who has served 2 terms representing the great state of California. He sits on the House Ways and Means Committee and the Budget Committee. The congressman co-sponsored the Chronic Disease Flexible Coverage Act earlier this year that expands coverage options for preventive care under high deductible health plans, as well as the HOPE Act. And he has also supported legislation aimed at expanding access to telehealth services and discussed the importance of requiring health plans to update their provider directories annually in order to reduce out-of-pocket expenses for patients. So let's see, I've got Jake on. Do we have the congressman yet? I got a note from John that Congressman Moore is on. Okay. They're both coming from a vote on the House floor, so we are just anxiously awaiting them. Roy, was there anything else that you wanted to mention that might also help inform us when we get joined by the members?
Yeah, I think there may have been one more slide that didn't get addressed, but it's not important. The important thing is to understand that for the first time in 22 years, we've had a major expansion to the health savings account eligibility grouping. And to me, this is a step in the right direction where it doesn't matter whether the plan meets all the very technical requirements to be a so-called HSA qualified health plan. 20 years ago, there weren't very many plans with high deductibles. Today, it seems like every plan has a high deductible. And I've often thought, well, why does it matter so much that, some of these specific changes require people to have a plan that is, cut out of a specific cookie cutter. And, but the other ones who have very similar out-of-pocket exposure cannot contribute to HSAs.
Mm-hmm.
So I'm thrilled with this provision that allows individuals with the bronze and the catastrophic plans to become HSA eligible for the first time. And so if we can kind of think about how we might easily move that up the ladder to, say, the silver plans next. And then we can debate, how much further to go above that. And maybe ask ourselves the question, is there a really good reason why you have to have a specific health plan, given what we know about deductibles and out-of-pocket limits these days, even under the Affordable Care Act? So, I mean, definitely, I would argue that it would be wonderful if all Americans, regardless of the health plan that they are enrolled in, would be eligible to contribute to an HSA. We've all seen out-of-pocket costs go up over the last 20 years, and not everyone has access to some of the employer-based tools like flexible spending accounts and health reimbursement accounts. HSAs are in that mix as well at the employer level, but people like myself who are self-employed, we don't have those options. So the HSA really is the best option for us. And add on top of that, the HSA is completely portable. You can take it with you when you change jobs. You don't have to leave it behind when you switch employers. And so I think it can be a better long-term solution. I'm not advocating for the elimination of FSAs and HRAs, but I do think that there's some benefits that the HSA offers that those programs do not. And as Jake alluded to earlier, the ability to invest your funds and even save them for retirement really makes this a much more advantageous program for people to take advantage of. And so the easier we can make it for people to understand that and participate in it, the better in my book.
That's terrific. And I have gotten the latest information that Congressman Moore is on, and hopefully the technology will work such that he can be pulled in as a panelist. And oh, okay. So We just got a text that it's a member of his staff, but Moore and Panetta are still on the floor voting. Okay, great. So Roy, I've got you for a couple more minutes. So here's, I guess, my big question, which is many of the provisions that you were just talking about that didn't make it on, based on what I saw those particular provisions cost, they didn't seem that expensive. So from your perspective, what are the reasons why they didn't make it into the final bill?
Well, there are a couple of them are expensive, and that could be one of the reasons why a few of them didn't make it into the final bill. But the interesting political dynamic was when the bill passed the House and then sort of was kicked over to the Senate. The Senate has its own rules, but the first draft of the budget bill that came out of the Senate Finance Committee, interestingly, did not include any HSA provisions, and that is the Committee of Jurisdiction. So that was kind of telling as to that we were going to be in for a little bit of a dogfight here.
Right.
So the industry had to work very hard to get those final three provisions into the final bill. It took a lot of work, and it took a lot of maybe hand-holding, as well as getting some members to speak up, not only to the chairman, but also to the Senate leadership and say, I'm not going to vote for this bill unless there's some HSA provisions in there. And so thankfully, that's what happened. I think we've all learned that if this comes around another time to maybe look at some of those House provisions that were left on the cutting room floor, that we are ahead of that curve before it happens, and don't find ourselves playing catch up.
Well, so, and this is a question really for both you, Roy, and Jake. I'd like you to answer it first, Jake, if you wouldn't mind, because you've got the data in front of you. You know, what you showed was there are relatively few account holders that are investing and contributing the maximum. So it kind of begs the question: are HSAs really fulfilling their purpose if we're seeing that level of utilization? Any thoughts on that?
Sure, that's a good question. When I see the fact that 15% of account holders are investing their HSA assets, you know, that might seem a little bit discouraging at first. But first, you see like the slow march of progress. You see that trend line slowly ticking upward year after year after year. And it could just be that these are still relatively early days. I know we just celebrated the 20th anniversary of HSAs last year, but it's still pretty early days. People are still figuring out how they fit in their personal finances. If I had a nickel for every time one of my friends confused an HSA with an FSA, I wouldn't be on this webinar. I'd be on a beach somewhere. But also, the strategy of investing HSA assets, it's not appropriate for everybody. If you would go into debt, put a broken leg on a credit card in order to avoid withdrawing money from your HSA so you can keep it invested, that's not an optimal strategy. Not everybody is going to be in a position where they can just cash flow all of their medical expenditures and keep their HSA assets invested. That being said, the fact that you can pay for your medical expenditures on a tax advantage basis certainly allows people to stretch their healthcare dollars a lot further than they otherwise could be stretched. And we did an analysis a couple of years back that looked at the zip codes of HSA account holders. It's not a perfect measure of income, but it is a really good proxy for income. We found that about half of the HSAs in our HSA database, about half the account holders lived in zip codes where the median household income was less than $70,000. So there are a lot of people who are benefiting from the ability to pay for their medical expenditures on a tax advantage basis and stretch their dollars a little bit further than they otherwise could.
Oh, sorry about that. I was muted. Roy, any thoughts on that question?
Well, I definitely agree with that. And some data from Devenir, who does an industry study, basically showing that almost 70% of people who have HSAs live in zip codes with incomes below median income of below $100,000. So there's plenty of data, I think, that supports that the criticisms that HSAs are only for healthy and wealthy people are not well founded. So I think that is a good thing. And looking at the growth trends over years, it's interesting how they seem to pattern the early days of IRAs as well as 401ks after they were created. So I do think it takes a while for people to understand what the new account is, how it works, kick the tires a little bit, understand what the value proposition is for them. And as Jake said, when we see people starting to invest, that's when it seems like the light bulbs have finally gone off and people start to understand, oh, this is my money. It doesn't expire at the end of the year. Um, I'd be right there with Jake as far as the nickel for every time somebody said they had an HSA and it's not. So it is part of the alphabet soup of employer health benefits, and we all have to understand that. But in this case, the S is for savings, not for spending, although it certainly could be used flexibly as a spending account as well. Just a little bit more control and flexibility built into it.
Well, and maybe we just have to get better with our acronyms. I mean, FSA, HSA, HRA. I mean, come on, we can do better, right? One quick point that somebody put in the chat that I want to kind of double click on. You said that we know that a large percentage of the folks that utilize HSAs make less than $100,000. Are those the healthy people? So is there a correlation with that wealthy, healthy piece, meaning our younger folks who maybe aren't earning as much because they're early in their careers, are they the ones that aren't getting as engaged in these? Or do we definitely see that it's no, we break those two things up and it's really the healthy that the unhealthy are still engaging, as well as the healthy, as well as the people making over and under 100?
So I'll let Jake talk to that mostly because he has data on the distribution side, which I don't think he presented today. But certainly what I've seen is there's a fairly high level of utilization of those dollars every year. So it's almost as if they are using them as spending accounts, even though they may be savings accounts. So Jake, why don't you pick up on that and run with it?
Sure. So we segment our analyses by age as well as by a multitude of other different factors. And we do find that, your younger workers, your workers under 25, are not really contributing or taking out as much money. Makes sense because workers who are that young or just starting in their career, they might be very healthy, but they also don't have a whole lot of money to contribute to their HSAs. We find that generally the average contribution strongly increases as you increase in age. Your 25 to 34-year-olds are going to contribute more than your 25-year-olds, and so on and so forth, all the way up to 65. We see the contributions peak for 55 to 64-year-olds at about $3,800. And unsurprisingly, we see that distributions pretty strongly mirror contributions. We find that the average distribution is highest in that same group that contributes the most, the 55 to 64-year-olds. But we also do see that, the under 25, the population that you'd expect to be healthiest, their average distribution is about $800, if I'm remembering correctly off the top of my head. So, they're contributing about $1,000, taking about $800 out. So it's not strictly a completely healthy population that's just, enrolling in a high deductible health plan because they're healthy and don't expect to have any sort of health conditions at all. We also look at the propensity to take a distribution by age as well. It follows the exact same patterns.
Yeah.
The under 25 is least likely to take a distribution. The 55 to 64-year-olds most likely to take a distribution. So I would push back on the characterization that it's only for healthy people who don't expect to have medical costs, because we see that no matter the age, at least 30-40% of the HSA accounts in our database are taking a distribution, and that increases as the account holder gets older.
So Jake, if we were to put two pieces together, what you just said, as well as the fact that one of the things that seems to increase employee contributions is an employer contribution, some seed dollars going into the HSA. Is that potentially something that might work with those younger populations to get them going at an earlier age and to get those healthier folks more engaged and help the experience of the overall plan?
I think that the evidence seems to suggest so. It's really hard to establish causality in the database that we have, but the presence of an employer contribution is pretty strongly correlated with higher total contributions and higher total average balances, as well as the propensity to invest, which we all sort of use as shorthand for engagement levels. So there is definitely some evidence to suggest that having an employer contribution can be pretty helpful in either kickstarting a balance or nudging workers to be a little bit more mindful about their HSAs.
Right, right. Yep, that makes perfect sense. Okay. So a couple of the questions that have come in. Let's see here. And I believe there's some C-SPAN drama going on. So we'll see if we can, in fact, get the congressman, or maybe we'll just have to have a webinar part 2 with the 2 members in a second. But can you tell us anything about whether the account fees, if there are account fees for HSAs, especially if we're talking about investments, what do we know about those account fees for any contributions, withdrawals, et cetera, that may or may not impact utilization?
Sure, that's a great question. I think that, as we've said a couple times on this webinar already, we're still pretty early days, and I think that there's still a lot of sunlight to be shined upon this industry. I think that, much as you've seen with 401ks, once the spotlight is shined upon those, we saw some pretty significant fee compression. I'm a little bit, just because it's still such a nascent industry, I'm not 100% sure, and just because the market is fairly fragmented, whether there's been some systematic analyses on this. I know that when I was with Morningstar, I worked on a first of its kind analysis of the HSA industry as a whole. And one of the things that we looked at was fees for things like monthly account maintenance fees, investment fees. And so there is a little bit of daylight in between providers on that front. Some providers are a little bit charge less. Maybe they charge a lower or no monthly account maintenance fee, but maybe a higher fee on investments or vice versa. So I think that, the first place that I'd probably go to check for a comprehensive analysis on the fees of different HSA providers would probably be my former employer. And I think that, again, as the market matures, we'll probably see some fee compression going forward.
Roy, any comments on fees?
Yeah, I think we've seen fee compression already in 20 years. And so, like any other financial product, you do need to ask the questions and make sure that you understand what it is that you're buying. But at the same time, there is a lot of flexibility as to the design of each of these administrators' programs. And so I have confidence that you can find something that meets your needs and it's not going to break the bank either.
Great. So as we're continuing to wait, and we'll see if the vote comes to a close and we can get the members for just a few minutes. One thing that I mentioned as I was talking about introducing the members was the HOPE Act, which stands for the Health Out-of-Pocket Expense Act. Roy, can you give just a quick summary of what that is? Because there's a fair amount of buzz about it in our community.
Well, I think the HOPE Act has been described as essentially what would be a Roth HSA. And for those who might be eligible to participate in those accounts, they would not have the same tax advantages that the HSAs do. So you have to maybe ask yourself who would want to do that. But maybe there are things that they find that would be advantageous to them. They do seem to be more advantageous to those people who have lower income and are receiving employer contributions. But the industry as a whole is not the biggest fans of these types of accounts. They've been proposed for a number of years by John Goodman and others. To me, it also adds another acronym to the mix of the employee benefits soup out there, which I think is always challenging. We've already added ICRAs. We've added, other things that come along. And so we add that with HSA, FSA, IRA, HRA, 401k, COBRA, etc. It's no wonder employees' heads are spinning. And so, I think you have to look at what is going to make sense for the employee as well as the individuals who are offering these accounts. And it's not clear to me, how big of a business opportunity it's going to be to add something new to the already crowded marketplace. But we'll see if this legislation goes anywhere.
So sort of follow up when it comes to the legislation generally that we're talking about. As you know, Congressman Panetta sponsored the Chronic Disease Flexible Coverage Act, which, for those of you that are not familiar with it, it lets employers and health plans cover more high-value chronic disease prevention on a pre-deductible basis. And really, I think, generally speaking, the employer community supported that expansion, and in fact might welcome even more expansion for things to be covered pre-deductible. And Jake, I know that EBRI's done a lot of work in that space, showing how, if given the flexibility, employers are going to cover more care on a pre-deductible basis. So given that there's a fair amount of kumbaya, oh, and here we have Congressman Moore. Welcome.
Thank you. Appreciate it. Continue on. Don't let me stop what you all are up to.
Well, actually, we were just talking about something that I actually wanted to ask you. And again, thank you so much for joining us, and and thank you for all of the work that you've done on behalf of the employer community and their workforce when it comes to healthcare benefits. But we were just a second ago talking about the Chronic Disease Flexible Coverage Act, which Congressman Panetta sponsored. And we were wondering whether you thought that particular act, as well as any of the others that have passed the one chamber, might see daylight on the Senate side. So any thoughts on that, or is there anything else that you'd like to mention, since we've got you just for a couple minutes here?
Well, I do apologize. I'm coming in hot, as you could expect.
Right.
So I'm not fully really versed on exactly what we're going to see with what's going on in the Senate. I don't have any expectation that we see something positive out of the Senate in the near term, since they'll be dealing with the CR for a long time. But
right.
This type of stuff should be able to work through the process. But I don't really have a sense for what's going to happen next. I apologize.
No, that's okay. So, as you know, we did, and for the way, we should mention, thank you very much for your support and leadership of the HOPE Act. We really appreciate it. Any thoughts generally related to the provisions that didn't make it into the One Big Beautiful Bill Act, that relate to HSAs, that maybe we'll see coming down the pike at some point?
Yeah, it's tough. HSAs, the moment to be able to enact as much as possible is through a reconciliation process, because how do I say this properly? There is a significant amount of opposition to HSAs from the Democrat upper dais of Ways and Means. Major claims that they're like fraudulent, or that wealthy people just use them as a tax shelter, even though you're forced to pay tax on it eventually. Like, it just, for any of the funds used that weren't used for healthcare eventually. I don't think they're warranted, or if there is a loophole, it's not exploited much. And HSA should be far more bipartisan. So you're gonna see upper dais Democrats on Ways and Means block and not support. You've got younger voices, or newer voices, I'll say, less tenured voices on Ways and Means Dems that do like HSAs, and they're willing to vote against their caucus or their committee leadership. But That doesn't bode well for long-term passage. Offsets are becoming more and more difficult because yeah, it's fine. So it's tough, right? Reconciliation was the best chance that we could do any type of HSA. Hope Act was a very expensive bill on the outset, where we've worked to get that more reasonable, but not in time for reconciliation. So there is still glimmers of hope that there'd be movement, given that there is bipartisan support, but ultimately it's not going to be, HSAs aren't going to be a priority of Democrats for the next few months. And that's just something we're going to need to have happen to actually make it into law. We can get it done and pass through our House, but seeing it pass through the floor or pass through our committee, but seeing it pass through the floor is the part that we want to get to that point. So,
well, and obviously this webinar is being hosted by the Employee Benefit Research Institute, and we've got other researchers that are online. Congressman, is there anything specific, research or any information that the community, the employee benefits community, could provide to your colleagues, either on the same side of the aisle or across the aisle, that may help educate them a little bit more about the usage of HSAs and the benefits that they provide a variety of different populations?
Yeah, just highlighting how this is such a strong benefit to the middle and lower income Americans, right? Like, that's essentially what the Hope Act was trying to accomplish, was being able to provide these benefits to a broader swath of income levels. But what we have right now too is also highly targeted to middle income. So to make the claims that this is about, just wealthy tax haven type of stuff, and it's not like widespread type of claim, but the more you can showcase how it affects so many within the district. Or the other thing is, like, Utah and Minnesota are states that have a high penetration rate of HSAs. Explaining why that was the case, how that different state could do better job of benefiting and adapting or sort of adopting HSAs is more consistent. Like, those are all areas that I think you can do to convince lawmakers.
Okay, great. Yeah, well, I mean, as you know, EBRI has the largest, I think one of the only, if not the only, HSA database of its kind in the United States. So if we can't do it here, nobody can. So thank you for that.
Absolutely.
And I believe your colleague, Mr. Panetta, is trying to dial in now. So we'll see whether he ends up being able to make it in the next couple minutes. With respect to, as you know, an important issue over the years has been the expansion of the flexibilities to cover high value care delivered on site at employers, on site clinics on a pre-deductible basis, for example, primary care services, right? What do you think are I think I know what you're going to say, but what do you think are the prospects for that kind of legislation advancing? And again, if there's any information that we might be able to provide to members.
Yeah, it'll all be about the cost of the score.
Yeah.
That's probably what you assumed I would say.
Yep.
Because the concept, get it. But there just isn't going to be motivation to do high cost associated bills. Given how significantly, like, how much significant breadth I call it the mega bill. Sorry, the one big beautiful bill, working families tax cuts. I just call it mega bill. Make economy great again. That was my own name. Never mind. That's all. It didn't pass muster. Although I think people would like it now. Given the breadth of that one, taking on another bill right now with high JCT score is going to be tough. The offsets, spending offsets, where those are depleting, and the opportunities for those are fewer, as of having just used a bunch of those in the reconciliation bill. So, like I said, I'm a realist. If we want to debate the merits of something like that, that's a whole different discussion on the reality of what it would take to get through Congress right now in this moment, especially given sometimes Democrats' apprehension, or more tenured Democrats' apprehension on HSAs. So
and is it fair to say, as you know, there have been several members that have introduced legislation that would allow folks like, working seniors, veterans, TRICARE enrollees, American Indians, Alaskan Natives, to also be able to tap into HSAs to expand who can utilize them. Is your answer going to be the same when it comes to the ability to ensure that additional Americans can save for their health care by expanding HSA coverage?
I mean, I'm the guy that's co-sponsoring that's leading the Hope Act.
Yep.
And I believe that a broader swath of individuals should be given access to take advantage of HSAs. I think it's good for healthcare. It's good for preventative care. It's good for people to start thinking out ahead of schedule on things. And if they have a bit more incentive to do so, we could see outcomes later down the value chain of health treatments improve. So ultimately it's a lower cost. So yeah, there is absolutely value in it. That's why I've been willing to, even with a high scoring number associated with it, I do think in the long run it has positive benefits. We just need to get past that hump of that legislative sort of wrinkle with regards to getting this done. Again, it's got strong bipartisan support. Yep. And I'm hopeful that we can take bits and pieces if we have to now, look to what happened in the reconciliation bill and improve upon it, and help convince more of my Democrat colleagues how valuable these things are for middle and lower income Americans.
Well, Congressman Moore, I want to thank you so much. I know it has already been a very, very busy day for you, and we're grabbing you right off of your vote.
Yeah, that's what Panetta was probably dealing with right now.
I think that's exactly right. Those are the chats that I'm getting.
If Representative Panetta is able to join, I'm sure he's going to have just glowingly amazing things to say about me. He's I'm kind of like an idol to him, or a mentor in some cases. Someone that he looks up to quite a bit, and it's a burden that I have. It's a burden that's a cross that our
I mean, it's hard to be you. It's hard to be you.
I hope somebody relays this to him, or even clips it and shares it with him.
We will 1000% send the detailed notes of this conversation. Well, thank you.
Thank you all. Thanks for being engaged.
I hope that we or other members of the benefits community can hopefully call on you again to get some more thoughts, maybe a sit down fireside chat to talk a little bit more about what you'd like to accomplish once everything else is signed on the dotted line. So thank you again for your support of the community. And John, if we could just switch now to the final slide. We are already over time, but let's just kind of close us out now. So for those of you that are still on, thank you. But I know we went over, but it's so rare to be able to get a member who is actively involved in the legislation that we all care about, that we made the executive decision to just keep going. So thank you for those of you that stayed on. And I just wanted to remind you of a couple upcoming events that you can see on this final slide. On September 30th, we're going to talk about ICRA's, yet one more part of the employee benefit alphabet soup. October 22nd. Oh my goodness, we've got.
Sorry, I'm stuck in the booth as well. I apologize for being late. Obviously, we're stuck waiting on votes, and I'm glad Blake was able to get on, and really appreciate this brief opportunity. As you said, I saw that you guys are closing it out, Tammy, but just wanted to pop in and say, obviously, thank you for all of your support on the HOPE Act and what you guys are doing to advocate for these types of HSAs, especially here on Capitol Hill. I think they're definitely gaining momentum. We saw that with the fact that they were introduced in the reconciliation package, unfortunately taken out, but at least that lays the foundation for, I think, where we can go like I said, and as you heard from Blake, a bipartisan effort to support something that I think middle working class families tremendously rely upon going forward. So look forward to continuing to work with you, obviously, in the advocacy for these types of HSAs. Can't stress that enough. And just please accept my appreciation for you, like I said, continuing to talk about this, familiarizing members on this important issue, and like I said, how it's going to how it's going to help working class families for sure.
Well, just in case you were curious, Congressman Moore only had glowing things to say about you. And
oh, I completely will not say anything good about Blake. I think he's a horrible member. No, actually, as you probably heard, Blake and I are not just colleagues; we're actually really good friends. So much so that he's come out to my district. I've been out to his district. He brought his family out. I brought my family out to his. We've had dinner with our families together. So I feel very lucky to have someone like Blake Moore on the opposite, not just in Congress, but especially on the other side, to show that, look, we actually don't just work with each other, actually like each other and get along and have a good time. And he's a hell of a member, and look forward to continuing to work with him on this, as I believe and he believes, no-brainer of legislation that I think we can get passed as long as we continue to have the support from people like all of you.
Yeah, well, thank you again for your support of the HOPE Act together. And hopefully the two of you can pass along that kind of bipartisan fairy dust to other members as well, so that folks can continue to work really well together. And thank you, by the way, since I have you, for your sponsorship of the Chronic Disease Flexible Coverage Act as well.
Okay, yeah, great.
Really, really important legislation, really appreciate it. And again, I know that you are very short on time, but I hope this means we can call on you to get you back, maybe sitting down, fireside chat, to talk a little bit more about HSAs. As you know, EBRI has the only really robust HSA database in the country. And so we'd be happy to get your thoughts on what additional information you need, your colleagues need on either side, to be able to pass legislation that is important to Americans. So thank you for all of your support.
Well, thank you to EBRI, especially EBRI, to continuing their work. Like I said, you're right up my alley. I'm a prosecutor, and so I'm all about the facts. And the more evidence you provide us, the easier it is to make an argument for something as important like this, especially HSAs and passing the HOPE Act. So I got to go vote. They just called the third final vote. Thank you. Look forward to talking to you. More importantly, look forward to working with you. Thanks.
Thank you. All right. Okay, well, wow, that was terrific. I was just going to finish up and mention, don't forget about these upcoming EBRI events that are coming October 22nd. We've got the EBRI and SHRM Health Benefits Symposium, and then we will round out the end of the year on December 11th for the EBRI Financial Wellbeing Symposium. Thank you to those of you that were able to stick through it till 2:47, but I hope it was worth it to you. I certainly thought so. And hopefully we will get both congressmen back so we could have a deeper conversation, and so they can continue to give each other these tremendous compliments. Thank you so much for joining. And until next time, have a great rest of your day.